Nancy, that was awfully kind. I'm having a really bad day, and so it was nice to hear that I really wanted to be here and that I was happy. It is a privilege to be able to talk to you on behalf of the Vanderbilt Ingram Cancer Center. I'm the Chief Medical Officer of the VIC, as we like to call it. The Ingram Cancer Center provides care in the community in multiple locations, and I sincerely hope we never get to meet any of you in that circumstance, either for yourself or for your family. Today I'm going to talk about personalized medicine, and I'm going to talk about sort of the progress that has been made in oncology in the last, it's hard to say, 35 years since I was an undergraduate at Michigan in Ann Arbor. And I want you to feel free to interrupt me. You don't even have to raise your hand. You can speak up, although it probably will go a little smoother if you raise your hand. We will have time for questions at the end, and I'm very happy to entertain any questions. Today we're going to just talk about a general introduction to cancer, a primer, if you will, on cancer, and because lung cancer, colon cancer, and breast cancer are the most common cancers, I'm going to focus a little bit on those cancers specifically. This talk is based on a talk I gave to a group of pharmacists as an introduction to cancer a few months ago. I think it's an entirely appropriate talk to share with you because you're a learned general audience. But again, if I get ahead of myself, use terms that you don't understand, please stop me. I do want to talk about the Personalized Cancer Medicine Initiative, which is something that all cancer centers are becoming more engaged in, that is in dealing with the genetics of a particular cancer in order to direct treatment to a particular cancer. But Vanderbilt is really and truly, and I'm not exaggerating, and this is not Southern politeness, Vanderbilt is truly at the forefront of this. So I would like to address some very basic questions today, questions that might seem too obvious to talk about. Firstly, what is cancer? I mean, we all think we know what cancer is, and it's a little bit like saying we all know what sin is. We know all sin is bad, but you know, if lying is a sin, then telling your children Santa Claus exists is a sin, and that's surely not the same thing as other things we can imagine. So we know cancer's bad, but we aren't quite sure what makes cancer. And as I hope when you leave here today, you'll say, well, I thought I understood what cancer is, but it's not quite as simple as I thought, but I do have a better understanding of what it is. Secondly, we'll talk about how cancer is diagnosed, what this term cancer staging is and what it means. And we'll talk about some very basic things about how staging is done. And then we'll talk about cancer treatment and the context of cancer treatment, which is now based on the patient, the host's DNA, and the tumor, the cancer's DNA, two different sets of genetic material, two different sets of DNA, which are what make personalized medicine personal. So I just said lung, colon, and breast cancer were the common cancers. Prostate cancer is also incredibly common and is the most common cancer in men. These statistics are updated by the American Cancer Society every year, and if you look at men and women, and this is new cancer cases, there's about 800,000 cancers in men, about 750,000 in women. Prostate cancer, a unique tumor to men, is the most common in men, and breast cancer accounts for an almost identical proportion in women. So there is equal opportunity, unfortunately, in getting these diseases. Lung cancer is the next most common cancer and is the most mortal of cancers. More people die from lung cancer than from any other malignancy, and it's an equal opportunity event happening in 15% of cancers in both men and women. We'll talk a little bit about screening. There are tests available to help detect lung cancer early, breast cancer, prostate cancer. Also, there are early tests. This is somewhat controversial. We'll talk about that a bit. And colon cancer, also an equal opportunity event. 10% of patients with cancer have colon cancer. Again, a disease that can be screened for and found early, and perhaps even by that early detection be prevented from developing by the removal of polyps. Urinary cancers, cancers of the reproductive organs in women, of the uterus, cervix, and ovaries are common, and lymphomas are common as well. Some cancers are uniquely curable. Lance Armstrong, who had cancer of the testicle, had one of the most curable cancers. A cancer that is even more curable than testicular cancer is cancer of the placenta, choriocarcinoma. And women with choriocarcinoma have virtually 100% cure rate. And why is that so different? Well, because that's half not the host. That's half the father's DNA, and that lets the host immune system help attack it. So we'll talk a little bit about some of those concepts, the concept of the host immune, the patient's immune response to their tumor, and how that helps people get over it. We'll talk about why cancer's cancer and how we treat it. Ms. Adams kindly said I was good with money. I don't know that I'm good with money, but money is on all of our minds now when we talk about the economy and the expense of health care. Cancer is an exceedingly expensive disease. This is a very busy slide that looks at the 5 most common cancers going from left to right: breast, colorectal, lung, lymphoma, and prostate cancer, and looks going from left to right at the anticipated trends in expenses that are expected. And they're pretty expensive diseases with total annual costs in the millions of dollars, in the billions of dollars. It's an incredibly expensive disease, and these diseases account for most of it. But all the news isn't bad. Now, this slide is really, really difficult to see, and I don't want you to focus on the big picture. I want you to focus on the fact that these curves are all making a turn, and they're all coming down. This looks at time going across the bottom line and the risk of cancer, death. And you can see, for example, the top curve is trending down. So there are both fewer cases, and our cure rate is higher for lung cancer, colon cancer, prostate cancer, and breast cancer. These are all making progress. Again, I apologize I don't have a pointer. The black line up here is prostate cancer. You can see the death rate is going down. The blue line just below it right there is colon cancer. The death rate is going down. And the top dark blue line is lung cancer, the most deadly of all cancers. And the death rate from lung cancer actually has been going down over the last 5 years from early screening, from better treatment, and for lung cancer, most importantly, because people are smoking less. For females, there's a similar curve, except prostate cancer isn't there. And breast cancer is. That on this curve is this blue line. And it's beginning to go down too, from early detection, from mammography, from improved treatment with chemotherapy, hormonal therapy, and other specific biological therapies. And this is great news. I mean, this is really great news. I used to say it's a joke that the best way to not have cancer was to have a heart attack and die. We don't want people to do that. We all know that if you live longer, you are more likely to succumb to have an incident case of cancer. Cancer is generally a disease of older people. Well, why are we doing better? Why are the rates going down and the death rates going down? We have better understanding of the biology of the disease. We have new treatments that really are revolutionary and almost miraculous. We have better understanding of when to screen and when not to screen. We may have heard the controversy about whether a woman should have a screening mammogram at age 40 or age 50. There's no controversy that a woman 50 years or older should have screening mammography. No controversy at all. And there's no controversy that we know a lot about the genetics, the personalized medicine of breast cancer, and that we can identify women who are at such a high risk of breast cancer that we recommend protective or prophylactic mastectomies. So this helps downstream lower the death rate. Well, first things first, what makes cancer cancer? At the end of this, I'm going to say I'm not really sure. Your body has trillions and trillions of cells, right? It's the basic unit of life. And your cells are always, some of them are always dividing. And when they divide, they actually divide fewer times in your lifetime than you would think, because some are in rest and some are dividing and some divide more and some less. Blood cells, which are very well studied, divide a few thousand times in a lifetime. I would have thought it was a much higher number, but because they live on average a month, you can do the math that they don't have to divide more than a few thousand times, because we don't live more than a few thousand months. If we live to be 100 years old, right, we live 1,200 months. So you don't have to have that many cell divisions to make up a lifetime of cell division. And the process of cell division is called mitosis. That's when, and I'll show you a diagram of this, but that's when a cell replicates all its DNA and has an opportunity to mess up that replication and cause something that will itself result in cancer. Usually, the cell can correct those mistakes. One of the things I'm really interested in is safety in hospitalized patients and safety in patients getting treatment for cancer. And you know, if flying airplanes was like medicine, we would have, if they practiced at the level of mistakes we see in medicine, which is on average about 1 in every 100 events has a mistake in it in medicine, no one would get on a plane. But in medicine, we have a huge advantage over flying an airplane. It's a much more forgiving system. You can get a cut and it'll heal. Your doctor can give you the wrong dose of a medication and it won't affect you adversely, although we try to never do that. We know that it happens about 3% of the time. So your body can recover and does recover, and even when the DNA division goes wrong, your body, through a series of enzymes, can fix that. Yes, ma'am?
If you get a cut or if for some reason cells are damaged or destroyed, do they divide faster then to make up or replace?
There are growth factors that, yes, they do. In general, they do. And that's one of the reasons why scarring itself can cause an increased risk of cancer, because the scar stimulates more cell growth. So this is a schematic of a cell. The red and blue chromosomes or the red and blue figures in there are depictions of chromosomes. That's where the DNA resides. That's what is replicated before division. That's where the mistakes happen. These mistakes are called mutations, and they can be major or minor. In cancer, one mutation of and by itself usually isn't sufficient to cause cancer. But the second, third, fourth, fifth mutation allows a cascading of events that itself causes cancer. And that's why smokers, on average, have 20 different mutations in their cancer that are the result of years of damage from the smoke. Cancer cells have two basic features. They're growing out of control. And by control, that means they don't stop growing when they're supposed to. Now, a common thought is that cancer cells are growing wildly and quickly. But in fact, a cancer cell grows less efficiently, less effectively than a normal cell on average. And that's what makes them vulnerable to treatment. They're spending all this time trying to divide, and in that time they're trying to divide, their cellular mechanism is really working hard to make this DNA. It's taking all the cells, if you'll allow me to anthropomorphize this, all the cells' attention, and they're much more vulnerable to attacks with chemotherapy drugs or radiation. So we have mutations to the normal cells that regulate cells, that cause the cells to die when they're supposed to, and mutations can accelerate cell growth, not accelerate it over normal, but accelerate it from the normal state where a cell would not be growing in an adult except to repair itself. And cancer, like sin, is a bunch of different things. It's more than 100 different diseases that can be characterized by the organ that they originate in, or characterized by the DNA abnormality that causes it. And if you look at that DNA level of abnormality, cancer isn't 100 diseases, it's 1,000 diseases. I think we'd all agree cancer is a bad thing. You don't want to go to the doctor and hear you have cancer, even if you have skin cancer. And one of the huge mistakes young oncologists make, myself guilty of this in spades, is to tell people, oh, your cancer isn't very bad. Well, that doesn't go over very well, because your cancer is your cancer, and it's the worst possible cancer, except maybe the cancer your child would have. And cancer cells are dangerous for two different reasons. They spread. We've all heard this term metastasize. But that's not unique to cancers, right? If you get a wart, you can get another wart right next door to it. I mean, warts can metastasize too, but they're not cancer. Although warts are pretty similar to cancer in many ways, right? There's something that's growing. I've taken care, well, actually my wife, who's a nurse, took care of a child who had congenital warts on his voice box and voice tree and breathing tree, his larynx, and he actually died from these warts. He was an immunocompromised patient, and it was a horrible thing. But cancer and warts actually aren't that different. They can both kill you, they can both spread, they both have to do with DNA abnormalities. But the huge difference is we know that warts are caused by a virus, and we know they don't metastasize invasively into tissues, they just grow on the surface. But cancer's bad too because it can pinch something. Unfortunately, I would guess, how many people have had a family member with cancer in the room? I mean, and we all know that, thank you. I mean, that's most of us. And we all know it's a bad thing. And we all know that they suffered often some sort of pain from the growth of the cancer because it pushes on something. It pushes on a nerve, it pushes on a breathing tube, it pushes on the intestine. And even worse than that, sometimes it grows into a blood vessel and opens the blood vessel to the surface. So cancers are bad because they spread, because when they spread, they grow and push into things and tear into things, and they block them. So obviously it's a bad thing. If you look under the microscope at a normal cell dividing versus a cancer cell, normal cells sort of do normal things. They have a characteristic shape depending on the organ they're in. They have a characteristic pattern of division. They have specialized features that allow the cells to do different things, like in the intestine, absorb water or absorb nutrients, like in the lung to absorb oxygen, like in the pancreas to make digestive juices, like in the breast to make milk. And they lose those characteristic normal features of the cells. The cells become, the term is de-differentiated and disorganized. And they lose the clear boundary of the organs. My liver is right, I'm hoping. My liver is right here, and it's just right here. It doesn't grow into my chest wall. It doesn't grow into my intestine. It stays my liver. And if I, Super Bowl Sunday, have a couple extra beers, my liver will swell up a little and get a little fatty, but it'll recover. If it's cancer, it won't do that. It'll grow, and it'll grow into something, and it'll cause problems in that way. So this is a CAT scan, and I know in this day and age we've all seen CAT scans. CAT scans were actually developed with the money from the Beatles records by EMI Corporation in Britain. And they took all that money and they made computers that would take x-rays of all around a body at one time, and then with the computer they would reconstruct these images that then can be reconstructed in different dimensions. And this is obviously something top to bottom. CAT scans allow you to take pictures, and I like to tell patients it's sort of like looking at cherries in your fruitcake at Christmas. The cherries are all the same size, but they don't look the same size. It depends on where the cuts come. And the CAT scan gives you a picture of cuts, and this happens to be a CAT scan that shows a big tumor cleverly marked in the yellow on the patient's right side. X-rays are always displayed as if you were looking at the person. So that's a person standing up, his right side. this is the kidney, this is the spleen, this is the spine, these are the hips, and that shouldn't be there. That's a tumor under the lung over the liver. The white thing on the other side, this thing is just the very back of the aorta as it curves around. But that's a tumor. Now, there are benign and malignant tumors. And in the simplest terms, benign tumors are tumors that don't kill you, and malignant tumors are tumors that do. But again, it's not quite that simple. Benign tumors generally don't invade into things, they push on things. And you know, in Kindergarten Cop, there's this famous line when Arnold Schwarzenegger says to the kid who has a headache, "You think it's a tumor?" Well, we worry about that in everyone. So benign tumors don't spread to other parts of the body. They can be removed and they can come back, but they seldom come back. And they're rarely life-threatening, but benign tumors can be horrible and can be life-threatening, but that's very unusual. Malignant tumors generally invade and destroy the tissue around them, and they've metastasized from one part of the body to the other, and often they are life-threatening. So why is that travel dangerous? Well, your head is a closed space. If you have something growing in there, and many cancers can spread to the brain, that's a problem because it can smush your brain and cause you to stop breathing. And I am from Indiana, I'm a Hoosier, and I live in Tennessee, and I'm still a Hoosier. And lung cancer that spreads to the brain is lung cancer. It's not brain cancer any more than I am now a volunteer, although I'd like to be, although I'd rather be a Commodore, but that's another story. So cancer is uncontrolled abnormal growth of cells. Cancer results from mistakes or mutations during the process during which cells are growing. And tumors form from a mass of cells coming together and growing out of control. And there are two types of tumor, benign and malignant, and generally only the malignant ones are termed cancer. There are major distinctions in cancers, and you know, doctors are lumpers or splitters, and most doctors are splitters, and they like to divide things up. This prognostication of cancers based on what we call them and where we think they originate is very important, but is less important than the genetic abnormality. In a couple minutes, I'm going to talk to you about a gene called ALK, ALK, which stands for anaplastic lymphoma kinase. It's called anaplastic lymphoma kinase, and it's a lung cancer gene where it has great applicability because it was discovered in lymphoma, but it's more common and treatable in lung cancer. So we care about where a cancer originates. You care that I'm a Hoosier, although I'm not in Indianapolis for the Super Bowl. You care that I'm a Hoosier, but you care more that I'm here now, and we care more that a cancer has a specific DNA and where it is. However, we talk about major kinds of cancer, cancer from the blood elements. Those are lymphomas and leukemias. Lymphomas begin in the lymph system. You all know what the lymph system is because you yourself or with younger people, when they have a cold, have felt these. I like being back in the South because if I call them kernels, you know, some of you will know what I mean. But you get these, if I call them rhisons, you'll really wonder about me. But you get these lumps in your neck when you have a cold. That's the lymph system, and they're swelling because your body's fighting off the cold. Cancers of the lymph system, the commonest cancer in children, are lymphomas and leukemias of the lymph and blood system. Carcinomas and sarcomas are similar in many, many ways, but doctors like to make a big distinction between the two. When you're a little blastocyst during embryology, when you're a little ball of cells, there's cells on the outside and cells on the inside, and because cancer relates to dividing cells, the cells on the outside are what become the carcinomas, and the cells on the inside, the blood cells, the blood vessel cells, the bone cells, the muscle cells, the fat cells are what become sarcomas. And Vanderbilt has one of the best sarcoma programs in the world because of our orthopedic oncologists and our pathologists who study more of these than other cases. and it's really one of the strengths we have over there. So a cancer is named based on the organ that it starts in and the kind of cell that it starts from. Colon cancer starts in the colon, and it is derived from the cells on the inside of the colon that are the cells that absorb water and food. Yes, sir?
What is the cancer called that starts in the liver?
There are several kinds of cancer that arise in the liver, but the commonest one that's seen in patients with hepatitis is called hepatocellular carcinoma, or hepatoma. One of the first cases of cancer I saw as a medical student was a 4-year-old boy who had had an exchange transfusion at birth, had gotten hepatitis B, and consequent to that had had a hepatocellular carcinoma or hepatoma. It's actually a very common cancer at Vanderbilt. We see a lot of cases here, but it's also one of the most common cancers in the world, where it's seen in Africa and Asia, where many people have hepatitis infection. Metastatic cancer is called colon cancer in the liver, is called colon cancer in the lung cancer in the liver. It depends on where it originates and where it goes. So cancer of the prostate, for example, which very commonly spreads to the bone, is not really bone cancer. It's prostate cancer in the bone. And I think medical students don't get this, so I don't feel bad if you haven't thought of that before, because it's a very difficult concept. And here's my Ohio thing. I'm still a Hoosier, but my daughter is still a Buckeye, even though she lives in Scotland now. The stage of cancer is something I'd like to talk about a little bit. And the stage of cancer is a little bit like me being a Hoosier. It doesn't change. The stage of cancer is something that for doctors means how it started. And your stage, this is very difficult to understand, but the stage of cancer never changes, just like the kind of cancer doesn't. The state of a cancer does change. So your cancer can be stage 4, widely spread, but in remission, where we have no evidence of it in you. And that word in remission is the state. The stage is how it started. Similarly, you can have a very early skin cancer, a melanoma, that was stage 1 or 2, and it is still stage 1 or 2 when it recurs, but the state is metastatic. Incredibly confusing. Oncologists don't get this right. I don't know that it's the right convention to have, but the rules of the game are that the stage doesn't change. And that's so we can compare cases from one institution to the other. So we can say that at Vanderbilt we have 20% of our breast cancer patients are stage 2, and at Tennessee Oncology, Sarah Cannon, which is not Vanderbilt, it's another group here in Cincinnati, here in Nashville, very similar to my group in Cincinnati, a big group. Not Vanderbilt, not the Vic, remember, Vanderbilt Ingram Cancer Center. But we can compare our results, and the state of Tennessee does that. The state of Tennessee collects information on all the cancers in the state in a year and compares the outcomes for patients from one place to another. This is the liver, and all those white things that look like cauliflower in the liver are cancer. It happens that that's pancreas cancer. So that is metastatic pancreas cancer in the liver, not really liver cancer, not a hepatoma. Not a good thing, but in some strange way, sort of an interesting thing to look at, and a strange thing. But you can see why that would hurt to have something like that there that shouldn't be there. But I remind all of you, particularly you women that have had children, that you had a 6-pound tumor that was in your, in your belly, and you were able to pretty much do what you wanted to do. You can have a lot of foreign cells in your body and still function normally. And cancer cells are very similar to your own cells, so your body doesn't react to them, so you don't necessarily feel that sick even when this is going on. So what causes this terrible thing? We're all made up of cells which all contain genes, and the genes can be mutated, and that mutation several mutations adding up can lead to cancer. It is almost unheard of for a single mutation to cause cancer. It's much more common for multiple hits, so to speak, causing cancer. But one of the reasons that childhood cancer, fortunately, is so much more curable than adult cancer is that those cancers have fewer mutations, have fewer abnormalities, and so you have to fix less to fix the patient. So a normal cell has a series of mutation events that occur to them. Most of them don't cause cancer, but through bad luck, if you have enough mutations in enough places, you end up with cancer. I don't know how the ER got erased from this, but risk factors for Canc, for cancer. Certain environmental factors, particularly sun exposure, smoking, can cause normal genes to form cancer. Certain viruses can cause cancer as well. Human papillomavirus is much in the news now for a variety of reasons because it's controversial whether we should vaccinate children for it. But both men and women, actually there was just a paper this week in the New England Journal that men have a higher rate of infection with human papillomavirus, and the head and neck cancers and some upper esophageal cancers come from this virus and its damage to DNA. So as I round the corner on 60, I can tell you that growing older is not a pleasant subject to talk about, but it is a risk factor for cancer. Things just wear out as we get older. Tobacco, particularly in conjunction with alcohol, and I enjoyed smoking when I was in college. You know, there's definite problems with it, but there's certain advantages to smoking. But tobacco in combination, particularly with alcohol, is a risk factor for cancer. Ionizing radiation in sunlight is a risk factor, particularly for melanoma, a skin cancer, which is seen in the highest incidence in countries like Australia, where people spend a lot of time in the sun. The only way to not have a family history, other than being adopted and not knowing it, is not to be born. And I think parents of children always feel terribly guilty when they're told they have cancer. But you know, I try to tell people not to feel that way because they didn't start it. And certain viruses and bacteria can cause cancer. One of the more interesting cancers to me is cancer of the stomach that's caused both lymphoma and adenocarcinoma of the stomach, which are caused by this bug, H. pylori, which is a bacterium. And when people have it, they have a greatly increased risk of cancer. So as all these things are being elucidated, we're learning more. Poor diet is the bottom of the list. I'm not sure that really causes much cancer, except perhaps in Asia, where people eat this incredibly strange smoked fish and have a very high risk of stomach cancer. And some cancers, some chemicals, for example, people who work in the dye industry in unsupervised countries can have an increased risk of bladder cancer from absorbing the dyes, which are then concentrated in the urine and excreted. But age is the biggest risk factor, and you can see from this graph that the number of cancer cases goes up pretty regularly with age, pretty linearly with age. And certain behaviors, the number of cigarettes you smoke being notable in 3 different studies, this is what led to the Surgeon General's report, cause an increased risk of lung cancer. So all cancer is genetic, that is, it's the result of abnormalities of the DNA, but not all cancer is hereditary. What does that mean? We're talking about personalized medicine and the individual DNA in the cancer. And you all have heard of families where it seems like everybody gets cancer. And there are family syndromes of stomach cancer, family syndromes of colon cancer, family syndromes of lung cancer. So we have the host, the patient's DNA that they're born with, their germline DNA, and we have the tumor's DNA, which causes cancer, the somatic DNA it's called. So all cancer is caused by DNA abnormalities, but not all occurs because of the DNA basis. Sporadic cancers, 90 to 95%, result from acquired DNA mutations. Tobacco, sunlight, radiation are the things that typically cause it. And a small proportion come from germline mutations, which is passed on to the child to from one or both of their parents. So these are people who are born with a gene mutation that either makes them very susceptible to cancer or of and by itself causes cancer. That means that you have to have less insults to your DNA because you're starting off messed up. Even having an inherited gene mutation does not always mean you'll develop cancer, because your body still will try to get rid of cancer tumors as they develop. You may have heard of this thing, BRCA, breast cancer, genetic mutations 1 and 2. About 5% of people with breast cancer have one of these mutations, and women who have this mutation have a 65% chance of getting breast cancer by age 70. That compares to a 12 to 15% chance of getting cancer if you don't have the mutation. So people who have this mutation identified one way or another, we recommend prophylactic mastectomies, and because this gene confers risk for both breast and ovarian cancer, which interestingly are more susceptible to treatment than the routine cancer, we recommend that women who have this mutation have their ovaries removed as well. Men who have BRCA2 have a highly increased risk of prostate cancer. Familial adenomatous polyposis is not only hard to say, but a common cause for causing cancer. And though less than 1% of colorectal cancer is due to this gene, if you have this gene, you have almost 100% chance of getting cancer. This is a hard picture to see, but it's better in the diagram. Your normal colon is smooth and just has these muscle walls on it, but in familial polyposis you have all these polyps, and you just can't possibly get rid of all of them without removing the whole colon, and those people eventually almost always get cancer. So cancer results from uncontrolled cell growth, changes in the DNA, environmental factors, and multiple mutations. And we talked a little bit about screening tests, colonoscopy, age 50 or younger age with a family history, with the age at which you should have it dependent somewhat on the age of your family member who had it. Mammography clearly at age 50, probably at age 40 for many women who have a family history or any of the risk factors. The single greatest test to reduce the risk of dying from cancer is the Pap smear, which is controversial as to when it's recommended now, but clearly should be done in sexually active women above the age of 18. PSA, even more controversial because it's not clear that early intervention in prostate cancer really makes a difference. And there was just a recent study that smokers, heavy smokers, more than 1 pack a day for more than 20 years should have a chest CT at age 50 or greater, because that will decrease the mortality. What, breaking up? Did I have my hand over it? I don't know. I need to tell a joke now, but I don't have any. Cancer, yes.
Cervical cancer, if you've had a hysterectomy,
If you
still get cervical cancer?
If you've had a hysterectomy, you cannot get cervical cancer, but you can still get cancer of the cells on the side of your.
Should you still have a PET?
You should discuss it with your gynecologist. See how I've learned to say that. But in fact, I mean, there are many reasons to still have an exam. The Pap smear may be the least important part of the exam. Women with a history of their mothers getting estrogen during pregnancy, which was common in the 50s. So if your mother took it when you should, the children of women who got diethylstilbestrol in pregnancy have a greatly increased risk of vaginal cancers, and they need to have this tested. So the T&M cancer staging system, I'm not going to go into any great detail, but this deals with the T, the tumor size, the N, the lymph nodes, the M, whether it's metastatic or not. You look at the different parts of the body to see what the lymphatic system involvement is, and lymph nodes are commonly involved in cancer. They're the first defense in it. This is a schematic diagram of the lymph system, which includes the tonsils and the thymus and all the lymph nodes in the spleen. And again, you know what the lymph nodes are from feeling kids' necks when they have a cold. Cancer in general is grouped stage 1, 2, 3, and 4. The gynecologist confused us. Used to ovarian cancer used to only be 1, 2, and 3, and certain other cancers were 1, 2, and 3. But now I think all of them are 1, 2, 3, and 4. And in general, a lower stage is usually a better prognosis. But you know, stage 1 lung cancer has a worse prognosis than stage 2 melanoma or breast cancer. So they aren't comparable across diseases. I use information about a cancer stage to find out where people are starting their trip. I always say to people, you know, we have to complete this staging to know how we're treating you, just like when you're telling me you want to go to Chicago. If I start telling you how to get to Chicago and don't stop to say, where are you starting from, my instructions aren't going to be very good. And you have to, with a patient, know where we're starting from. That's the whole point of staging. Breast cancer, I'm going to go through these pretty quickly. The genetic predisposition is important. Family history, if you have a family history, you have twice the risk of breast cancer than if you don't. So that's 1 in 4 versus 1 in 8. And if you're BRCA1 or BRCA2 positive, that's important. Hormonal environment may be important in breast cancer. Women who are pregnant multiple times and breastfeed, which suppresses ovulation, have a lower risk of breast cancer. Screening test is a mammogram. That's critically important, as we've talked about, and breast cancer that's involving the lymph nodes, as depicted in this diagram on the right here. These green things are the lymph nodes, and these swollen lymph nodes are cancer involved. Yes, ma'am.
Does the age of your mother make a difference, you know, when she first got it?
Absolutely. And women who get it over age 65 or 70, the risk is not very much greater for their daughters. But a woman who gets it at age 35, and we all unfortunately know people like that, have a greatly increased risk. But again, their children are, I think, better off for being here. So stage 0 disease is not invaded into the body. It's just on the very surface of the breast. And if you think about it, anything, when I open my mouth, my stomach is really on the outside of my body, and since the breast secretes milk, all those ducts in there are really on the outside, and an early cancer, even in the duct that doesn't cross the membrane, is still technically outside. When I was in medical school, everybody said, you've got to stop describing things like fruit because nobody knows what you mean. But I would wager that if I say the tumor was the size of a lime, you have a much better idea of how big it is than if I say it's 5 centimeters. And none of you has any doubt knowing that a lime is bigger than a walnut, which is bigger than a peanut, which is bigger than a pea, I think. But we're not supposed to do that as doctors. Treatment for breast and all cancers is generally one of 3 modalities. Surgery, cut it out. Goes back to the Egyptian times when the first mastectomy seems to have been described. Radiation therapy to the whole breast or part of the breast, a controversy now, are the local treatments, and systemic treatments are medication. Adjuvant treatment is a concept that most residents I work with don't understand. Adjuvant treatment is cancer treatment after you have some definitive treatment. You have a mastectomy, a lumpectomy, whatever. You have your colon removed. You have a lung tumor removed. And after that tumor is gone, when we, the physician, and you, the patient, really think it's gone, we give the treatment then to keep it from coming back, and that's termed adjuvant therapy. A surgeon, it pains me to admit that a surgeon figured this out, not a medical oncologist. It was a guy named Cooper. He was a Park Avenue surgeon in New York, and he said, I hate seeing these women come in here with recurrences of their cancer. If they have a recurrence after I did a mastectomy, it must be that the cells were there. So why not kill them right then instead of waiting till they come back? It was a brilliant, brilliant idea. Colon cancer, you can screen for that with a colonoscopy, as I said. The primary tumors in the colon are used to be mostly in the rectum. Now they're mostly in the cecum. This is the colon. going up and around, and the appendix is down here, and that's where most of the cancers are now, so you really need a full colonoscopy to discover those early. The way the tumors invade from the colon is from the inside out. Excuse me, from the outside in. They come from the inner area of the colon and then go through the muscle. We'll keep the Super Bowl imagery going. If you have chitlins, that's the walls of the intestines, although it's the small intestine. And the colon cancer invades through the muscle, and when it invades through the muscle is when it has access to the blood system. Stage 1, colon cancer has not spread to the lymph nodes. Stage 2 has not spread to the lymph nodes. And stage 3 is involving the lymph nodes, which are depicted in green here outside of the colon. Stage 4 colon cancer is metastatic and is spread to other parts of the body, most commonly to the lymph nodes distant to the colon and to the liver. Again, the treatment for colon cancer is surgery. There are patients who benefit from chemotherapy after surgery, adjuvant therapy, and in advanced disease we have a variety of treatments we can give. Adjuvant chemotherapy I've defined for you previously, and in colon cancer it happens to be indicated in people who have lymph node spread of their tumor. Lung cancer, as we said, is the greatest cause of death. It's clearly related to smoking, although there are increased numbers of cases diagnosed in non-smokers. And it seems that the way we're finding lung cancer cases is changing. In addition to smoking, asbestos, if you can't sleep like me and you're watching TV late at night, you see this guy come on and say, "Do you have mesothelioma?" That's a very interesting father-son pair. The father is an oncologist, the son is a lawyer, and they have made a career out of asbestos litigation. And asbestos causes mesothelioma and regular lung cancer. Radon, we all get our basements checked for radon when we buy houses, seems to have an increased risk for lung cancer, and there is an increasingly recognized number of people with a genetic predisposition to lung cancer. As I said earlier, there was a recent study that showed that screening CT scans, low-dose CT scans, help detect lung cancer early. As you may or may not know, in this political year where you can't turn on the TV without hearing some political discussion, Medicare does not pay for screening tests unless they're specifically included in a law that says they should be included. CT scanning for lung cancer is not paid for by Medicare, and it costs about $300 and won't be covered by that. And there's an argument that can be made that the number of cases you find and the expense of finding them and the anguish you put people through unnecessarily who have a so-called false positive test really make the benefit of this marginal. This is, however, the graph of the improved detection of lung cancer and the decrease in the death rate in people who had CT scanning versus other. These are the kind of curves you see in oncology where you look at the total number of deaths over time, but this is in 50,000 patients and the number of deaths is 300. So you do save 100 lives, and there's nothing trivial about that. If I said to everybody in this room, I want you all to stand on your head for an hour so that one of you can live, you would all do it. You wouldn't think twice about it. And that's what adjuvant therapy is about. We have 100 patients, we give them the treatment, and 5 of them do better, but we've asked the other 95 to stand on their head. Under the microscope, this is a picture of lung cancer. The staging for lung cancer depends on whether it's so-called small cell lung cancer or non-small cell lung cancer. This is a chest x-ray up here. All this stuff up here shouldn't be there. That's a very typical pattern for small cell lung cancer, which is clearly smoking related and very aggressive. So aggressive, in fact, that it's not treated with surgery. Non-small cell lung cancer is generally only treated with surgery. Small cell is treated with surgery and with radiation and chemotherapy. And adjuvant therapy in lung cancer is given after surgery to help lower the risk of reoccurrence. So I want to talk just one more minute about the DNA in lung cancer and the abnormality, because this is really work that's done at Vanderbilt by William Powell. William Powell is the head of my division, the Division of Hematology Oncology, which is part of the Department of Medicine. He got a PhD in New York in this guy Harold Varmus's lab. Harold Varmus won the Nobel Prize for the work I think William actually did all the work, but Dr. Varmus won the Nobel Prize. And what he discovered was that this genetic abnormality, the ALK protein, ALK, anaplastic lymphoma kinase, was present in lung cancer cells and really revved up. And if you have a drug that sticks to that DNA and turns it off, you can make the lung cancer go away. And so they've discovered this personalized drug that works on this genetic mutation. There are different mutations in lung cancer with other proteins, the so-called epidermal growth factor receptor, which when mutated confer a response to treatment with a drug called erlotinib or Tarceva. And these responses are miraculous. I mean, the patients have tumors that you can see and feel, and you give them these drugs, and they literally in 2 weeks go away. It's amazing. The prototype drug for this was called imatinib. It's a drug that's used for chronic myelogenous leukemia, an incredibly rare disease, well, a very rare disease, not incredibly rare, but very rare, that used to have an average survival of 5 years when you had this disease. Now people live, we don't know how long because the drug is only 5 or 6 years old, but everybody who takes this drug seems to go into remission. Now you can talk about the ethics of selling this drug for $4,000 a month, which is what it costs. But I personally would be happy to pay it if I have a drug that makes a difference between me having cancer and me being in remission. And all these drugs are sort of this level of expense, but have this kind of effect. So we now, when a patient comes to us with a cancer, study the DNA if it's lung cancer, study the DNA if it's colon cancer, study the DNA if it's melanoma, and use the results of that study or some of the downstream proteins from the DNA to determine treatment. And it makes a huge difference. The Institute of Medicine has a big push to give the right drug to the right patient at the right time. I think you've all heard that. In fact, there's signs all over Vanderbilt that say it. But that's based on the DNA of the patient, the DNA of the tumor, get the right drug, whether it's Tarceva or erlotinib for lung cancer or crizotinib for lung cancer or imatinib for chronic myelogenous leukemia. And every day there are going to be new ones of these drugs. And the FDA has said, you know, it used to be you needed 1,000 patients to tell if a drug was actually helping. The FDA has said now it's going to take less than 100 patients to tell if a drug is helping. And this is going to revolutionize the drug approval process. However, because the mutations are rare, we're going to have more patients to study to find the ones who might qualify for the drugs. So I'm going to answer questions now in general, but go ahead.
Do you test for the DNA in all types of cancer now?
We do not test in all types of cancer. We only test when we have a so-called actionable mutation, which is a mutation we can do something about. On a research basis, we do study the DNA from all cancers. But for any individual patient, we don't study it because we don't know what to do with the information. We don't know what it means. And it distracts us from testing in patients where we do know what to do when we find the abnormalities.
Do those medications that you're talking about, do they have the same side effects as the old meds that they use?
They have different side effects. They're not totally innocuous because these genetic abnormalities are very fundamental to the cells, but they are generally much, much better tolerated than the sort of, you know, make you throw up your toenails and your hair come out. Yes, ma'am.
Would like a little more explanation as to why the DNA of the tumor, which is part of the body, is different from the DNA of the body.
It's a great question, and I'll repeat it. Thank you. The question was, why is the tumor DNA different from the body's DNA? Because the tumor's still in the body. And the smart alecky answer is because it can be. Because each independent cell has its own DNA, and each bit of DNA in every cell, when it divides and is replicated, is unique to that cell. So I have 2 cells, and they both divide and become 4 cells. In one of these cells, the DNA is screwed up. That cell is then 2 cells, 4 cells, 8 cells, different than the others. And that question is actually, I'm not on runway in Arizona. I'm not pointing at you. I apologize. DNA changing continues to change, and that's why when we have these miraculous drugs, eventually they stop working, because what was one cell that was resistant to the drug becomes, or that didn't have the mutation, becomes 2, becomes 4, becomes 8, becomes a tumor oven by itself. And that's the other reason not to study the DNA on the original tumor, but to study it later if, God forbid, the cancer comes back.
But there are no, there's not a diversity of DNAs throughout the body.
There's a tremendous diversity of DNA at a molecular level.
One person.
One person starts with one set of, actually, it's not quite that. We have, everything you learn in medical school is eventually proven to be wrong. And the DNA is very similar in all the cells originally, but it's the DNA that gets messed up in a couple of cells down the road that leads to the tumor, that leads to the billion cells, which is very distinctly different. However, you have millions of base pairs in the DNA, and you're looking for a single mutation, which is very hard. Yes, sir?
What would you suggest, other than not smoking, as far as lifestyle choices, diet, et cetera, to sort of combat?
The question is, what are lifestyle interventions that can help prevent cancer? First of all, I'd like to say unequivocally that having a good attitude does not help you survive, helps you neither survive cancer. And I think that's important, because I think a lot of people go to cancer patients and say, buck up, if you have a positive attitude, you'll be fine. There are many, many studies that show your attitude has nothing to do with your survival rate. And I personally, now I'm on my soapbox, think it's really unfair to put that burden on somebody who has cancer to say, well, if you just had a good mood, you'd be better. I mean, come on. My boss, the cancer center director at the Vanderbilt Cancer Center, Jennifer Pietenpol, thinks a high-fat diet is the next most important thing after smoking, and thinks that avoiding a high-fat and actually promoting a high-fiber diet, low-fat, high-fiber diet is the best way to prevent cancer in someone. I think the best prevention to cancer is early death from a heart attack, and I'm not entirely facetious. I think if you live long enough, you're going to have cancer of some kind or another, because cells just wear out; they get tired. Yes, ma'am.
I'm concerned about the cost of the cancer treatment. At Vanderbilt, do they have an ethics committee or a way of determining, let's say, choosing maybe a healthy young mother who has stage 3 cancer, and then you have a 90-year-old that also needs expensive treatment? How do you determine, or is there a way you can determine who gets the treatment?
Well, I'll tell you a story. One Christmas day, I was making rounds in the hospital, and there was a woman who needed platelets every day, and there was a shortage of platelets, and this woman was bleeding, and if she didn't get this transfusion, she would bleed. And I said to her husband, I'm sorry, we can't give her any platelets today. We don't have many in town. And they all went to Children's Hospital, where, of course, those patients need it. And this man looked at me and barely could contain himself from hitting me. And he said, no one is more important than my wife. How dare you ration that? How dare you say that it's more important to give it to the child? And I think, you know, we heard about the death panels. We heard about the committees that would make that kind of determination. In Great Britain and the EU, they have the Institute for Comparative Effectiveness that does just that, that says if a drug costs more than a certain amount, it's not allowable for cancer patients. In the United States, because of the cost of dialysis, remember there were panels to see who would get kidneys and who would be put on dialysis in the 60s. And those panels decided that it was unethical to withhold the treatment from anybody. Medicare was expanded to include all patients with chronic renal failure, and it happens to cost about $100,000 a year to provide that service, and that happens to be the price break point that most people are seeming to be approaching with these life-saving drugs. Huge and important issue, and it really would help things if we could talk about it openly, because clearly there's a tipping point. Yes, ma'am.
Does Medicare and insurance cover the drugs that you were mentioning that are like $4,000 a month?
Part D, Medicare pays 80% of those drugs, and private insurance pays most of the expense of those drugs. Yes, sir.
I'll mispronounce it, but aplastic nevi or nevus, bad architecture of a mole. What's the propensity to lead to melanoma?
It depends. The question was a dysplastic nevus, what the rate of conversion in dysplastic nevus syndrome to melanoma was, and the answer is it's somewhat unpredictable, but high enough that a dysplastic nevus should be removed and all of them should be looked for. It depends on how big it is, how long it was before it was determined, but it is thought that given enough time, all of those turn into melanomas. Yes, sir.
Could you comment on the controversy these days on PSA numbers and the need for conjunctions and all that stuff that's going on?
Do you remember when Newt Gingrich said to John Rogers, that's an appalling question, I can't believe you asked that. I was just asked, can you comment on the controversy of PSA testing and the numbers and what it means? And I'm tempted to pull a Newt Gingrich here and say I can't answer that. But it's a very good question. It's a very important question. It's a very confusing issue. We believe that all cancer is bad, and we believe that having a cancer and not discovering it is giving up an opportunity to cure a cancer. The problem with those beliefs is the facts have not been collected to prove that. We know from autopsy series that most men who live long enough appear to have prostate cancer to some degree. And just because you have it doesn't mean it's dangerous. We know that the PSA screening increases the risk of finding cancer, but we don't know that intervening actually changes the death rate, except from slides where we look at huge numbers of population, which would seem to say it makes a difference. Men who have surgery or radiation for prostate cancer often become incontinent or impotent, and there's an old joke about the guy who goes for his prostate cancer surgery and he's wearing a tuxedo, and the guy says, "Why are you wearing a tuxedo?" He says, "If I'm going to be impotent, I might." The guy goes for his prostate cancer surgery and he comes wearing a tuxedo, and the guy says, "Why are you wearing the tuxedo?" He says, "If I'm going to be impotent, I want to look impotent." So there are reasons not to do it. Yes, ma'am. And forgive me for that.
Are there other countries that have less amounts of cancer under society?
There are, and the United States used to, and it is related. The question was, are there other countries with lower rates of incidence of cancer? And the answer is yes. There are countries where people have a lower life expectancy by and large. Some of the Scandinavian countries appear to have a lower risk of some cancers because of perhaps their diet, perhaps their genetic material. Yes, ma'am.
Oh, yeah, in one of your earlier slides that showed the type of cancer and percentage in men and women, there was a little disclaimer that basal cell
It's left, the American Cancer Society does not report basal cell cancer of the skin in their cancer incidence slides because there's so many of them and they are so non-life threatening generally. Although I've been doing this a long time, and I had 2 patients with basal cell cancers of their face who literally had had half of their face taken away by the cancer. It's just, and they were both hermits. They lived alone. Their kids would bring them their food and not come in the house. So basal cell cancers are not innocuous. They can be terrible. Yes, ma'am.
2 questions about women who who have had DES when they were pregnant. And one is, does DES have a predictable effect on the woman who took it? And 2, what about sons of women who have DES?
I don't know about sons of women who have taken DES. I've never heard anything that I can remember, but I will look it up because it's a great question. In terms of the mothers, they do have they have an increased risk of breast cancer, for example, but the risk is less dramatic than that in the daughters. Yes?
Is there standardization on the term family when you go to the doctor? Does that mean your immediate family? Do you go out to your grandparents, your uncles, your aunts?
So, great question. The question was, what's a family? How do you define family in terms of cancer risk? One of the things I do is write national quality questions for oncology practices, and I write it with a guy named Kevin Hughes, who is sort of the world expert in family history, and he designed a quality monitoring question to ask that question. And it turns out it's the history of all first and second degree relatives. So it's your mother, your sisters and brothers, your first degree cousins, your first degree aunts and uncles, and it's all those people who, if they have cancer, it confers a slightly increased risk to you. Almost no one takes a complete family history because almost no one knows their complete family history. Yes, ma'am.
The incidence of cancer is in offspring. I have 3 children, 2 of whom have had cancer. One's had melanoma, the other one died. That doesn't have any effect on me if it's the next generation.
First of all, I'm very sorry to hear that. Additionally, the question was, Ms. Strupp has 2 children who have had cancer, one of whom had melanoma, and one child succumbed to their cancer. What backwards effect does that have on her? The answer is it's not zero increased risk, but it's very minimal in terms of your personal risk. If you have grandchildren through that person, then the risk obviously for that child is very worrisome and high. Yes, sir, in the back.
What advances do you foresee in the next, say, 2 years in cancer treatment?
Great question. What advances do I foresee in the next 2 years? I think 3 things. I think number 1, we're going to have many more of these individualized drugs based on a patient's individual DNA that we're going to be able to give to the patient and really make a difference. Number 2, I think we're going to do a much better job of collaborative care where instead of you see the surgeon and he says one thing and you see the radiation oncologist and she says something else and you see the second surgeon and she says something different and the second, I think we're going to get together at the beginning. I think in the New York Times we've all seen that ad that says where you start your cancer treatment matters, and I think it's true that where you start your treatment matters. And I think one of the things I was hired to do is make sure every patient who comes to Vanderbilt gets a multidisciplinary evaluation before we start the treatment so we don't have to catch up. Using the metaphor of the trip again, I think starting a trip, it's more important once you start to know where you're going and how you're going to get there than starting before you have your directions all set. So I think that's the second thing that'll be important. And third, I really and truly think we're going to have this sort of balance between people living longer and having more cancer and people living better and having less cancer. And I don't know what impact that literally is going to have, but I suspect that cancer wins in the end, and there will be more cases of cancer even if we do all the right lifestyle things. I think we'll still get one cancer or another if we live long enough, because dividing cells just get messed up and we can't get away from radiation, et cetera. I'll take 2 more questions and that'll be it. Yes, ma'am.
I have a neighbor who's been diagnosed with anal cancer and also metastases to the liver. And she was told that cancer's like sugar. I mean, is that a valid statement?
The question was a patient who had metastatic anal cancer. Cancer's like sugar, and that may be why it spread to the liver one place or another. I don't know what was literally meant by that. I think cancers, all cells need sugar to live, and I think I can't believe that cancers like sugar more than other things. There's a very popular belief right now that cancers do poorly in an environment where there's a lot of basic material, like lye is a base, and so a lot of cancer patients are taking bicarbonate of soda to make their body more basic, because people believe that that will make the cancer not grow, and surprisingly, some of the people who believe this are really, really smart people, and I don't understand it at all. But you hear all sorts of things, and in the end, to me, it boils back down to the sort of blaming the patient for it. You know, patients go and they get these macrobiotic diets that no human being could possibly ever eat. I mean, you know, you take a 2x4 and grind it up, and then and then, you know, and then their cancer grows, and the doctor says, the macrobiotic practitioner says, well, that's, you know, they do point, and they say, that's your fault because you didn't do what I told you to. It's crazy. One last question, if there is one. All right. Yes, ma'am.
Do you think that ductal carcinoma in situ or lobular carcinoma in situ always would progress to invasive cancer?
No, the data are that those don't always progress. But the data are also that the treatment can help lower the rate of progression and improve the chance of surviving. So I think they're worth paying attention to and addressing, but they don't always lead to invasive cancer. But they are a risk factor for invasive cancer. It was a great pleasure talking to you.